Namaste Vidya, Khush Raho Vidya. Myself, Dr. ARTI BANSAL, Associate Professor, Department of Pathology in JAYOTI VIDYAPEETH Women's University. In my last video, you have seen about the Plasmodium's life cycle. Today, we are continuing this topic on the 7th May. Uh, let's begin with Plasmodium. If you have any query, please mention it in the comment box. I will try to resolve it. So listen carefully. Yesterday we have talked about the life cycle of the malaria. I'm just repeating that for a few seconds. See, there is a mosquito there. It bites the human, and when it bites the human, this sporozoid infected form goes inside the human, and there is a pre-erythrocytic cycle which run inside the liver, then exoerythrocytic cycle which releases the merozoites, which causes the uh, continuation of the erythrocytic cycle. But some of these merozoites will convert into the gametocyte, and if the mosquito will take the second blood meal, it will goes inside it, and this is converted into macro and micro gamete, and these form the eukinete oocyst. Then again there is an infective form which is a sporozoid, goes inside the jaw of the mosquito, and again when mosquito take the blood meal, this will transfer inside the human. Thus the cycle goes on repeatedly. This is not our topic today. Today's topic, we will discuss today about the complications done by the malaria and the clinical picture of the malaria. So let's begin with that. There are three stages in the clinical sign and symptom. One is the cold stage. First, there is a shivering, then there is a hot stage, then there is a sweating stage. All three stages run one by one. It is different. The time is different in all three stages in different species of the Plasmodium, like in the Plasmodium falciparum. This is the quotidian, tertian, and irregular pattern is there. Means there is a fever on the fourth day, on every third day, or there can be an irregular pattern. We can't say that when the fever will come. It is happens in the Plasmodium falciparum, but in vivax and ovale, almost erythrocytic cycle is 48 hours, and this is causing the tertian fever. That means if fever comes on the first day, that it again comes after the 48 hours of the third day. But in Plasmodium malaria, there is a fever after every 72 hours. This is called the quatern fever. So there is a pattern in the fever. In clinical picture, there is two type of disease. One is the acute disease and second is the chronic disease. In acute disease, non-severe acute febrile disease, it is causing the cerebral malaria, and sometime it will lead to death. But in chronic disease, some of the patients are chronic asymptomatic infection, which is causing the anemia, and there can be a developmental disorder and transfusion and death. But in some of the diseases, if there is an infection during the pregnancy, there is a placental malaria. Then after there is a low birth baby and increase the infant mortality rate. See, this slide is very important. Just try to understand this slide. The parasite developing in RBC. We are talking about the erythrocytic cycle of the Plasmodium. During when the parasite develop inside the RBC, in case of Plasmodium falciparum, the surface of the RBC shows some changes. There is an adherence of parasitized RBC to the endothelium, and there is, because of the adherence of the parasitized RBC one by one, there is a localized decreased microcirculation capillary. There is an intravascular coagulation in the capillaries, disseminated intravascular coagulation. This will lead to tissue anoxia. There is a hypoxic condition which is causing the different symptom. Every mechanism will lead to hypoxia in the tissue. And this hypoxia in adrenal, it is causing the shock. There can be a bacterial sepsis in the brain. It affects the hyperpyroxia and causes the coma. In gastrointestinal tract, it is causing the dysentery. In hepatic system, it is causing the jaundice. In pulmonary, it is causing the edema. In renal, it is causing the anuria, because there is a hypoxia which is systemic illness and which is causing every organ a particular symptom, and these symptoms again causing the tissue anoxia. In parasite, and the second mechanism where during the parasite development in the RBC, there is a defect in the metabolism of hemoglobin, which is causing the hemozoin formation, so that the iron storage depletion occurs, and this is again lead to anemia, and anemia will lead to anoxia. And the third mechanism through which the lysis of infected cell, because it is causing the lysis of the RBC. So RBC's lysis will lead to stroma, splenomegaly, the restricted RBC, where they will go. They will just go inside the liver, and which is causing the splenomegaly. And this is increase the destruction of normal RBC. Hemoglobin, hemoglobinemia, and in case of Plasmodium falciparum, there is hemoglobinuria, which is causing the black water fever. And lysis of the RBC, again, the antigen of the malaria, which is producing the antibody, and antigen antibody complex will form, and there can be a nephritis, because it will come out through the body by the nephrons only. So you can understand the mechanism, clinical sign and symptom. Now the malaria paroxysm, there is a 3 stages. I already told you there is a cold stage which is causing the feeling of intense cold, vigorous shivering is there, which lasts around 15 to 20 minutes. Then hot stage, there is intense heat, dry burning skin, throbbing headache, it lasts for 2 to 6 hours. Then there is a sweating stage which is causing the profuse sweating, declining in temperature, exhausted person is so weak and exhausted, this will last around 2 to 4 hours. And then after there is a comatose sleep. There is some uncomplicated malaria is defined as a symptomatic infection with malaria parasitemia, the parasite inside the blood, without signs of severity and evidence of vital dysfunction. This is called the uncomplicated malaria. But in cases of complications or severe malaria, as it happens in the Plasmodium falciparum, the following complications occur, which is causing the cerebral malaria, which is unrousable coma. Generalized convulsions can be there, severe normocytic anemia is there, hemoglobin concentration will reduce less than 5 gram per deciliter. There is hypoglycemia, glucose level will reduce below 2.2 millimole per liter. And metabolic acidosis occur, fluid and electrolyte disturbance occurs, acute renal failure occur, acute pulmonary edema is there, abnormal bleeding is there, jaundice, hemoglobinuria, circulatory collapse, and hyperparasitemia. As I showed in the last 2 or 3 back slides, I have shown you the mechanism. These all happened because of that. See, there is a picture of cerebral malaria where person is having the opisthotonus in unrousably comatose type. There is a pulmonary edema in this picture. The cerebral malaria, severe malaria will cause the pulmonary edema due to hypoxia. Now there is a signs of jaundice. You can see the signs of anemia there, because RBC is just destructed continuously. This patient is again on ventilator and having some clinical picture happen. Patients with glucose 6 phosphate deficiency, G6PD deficiency, may develop intravascular hemolysis and hemoglobinuria precipitated by Queen and other oxidant drug, even in the absence of malaria, because glucose 6 phosphate deficiency will prevent the patient by the malaria. I will show you some mutations which are preventive for the malaria. How the Plasmodium enhances the transmission rate. The Plasmodium parasite engage in the number of manipulative behavior which enhance its chances of being transmitted between the host. Some manipulation are a common feature of parasite behavior in general, as we will see throughout the semester. Now I will show you some mutations which you can see uh, effects of malaria on human evolution. This is all about what we have discussed, that the clinical features of malaria, how it happens, what is the life cycle of the malaria, how the disease progress, and it will causing the clinical sign and symptom. But there are some pre-existing diseases which of RBCs which are preventive for malaria. The intense selection pressure imposed by the malaria has resulted in large number of mutations that provide protection against the parasite being selected for in human. The best known is sickle cell anemia. What happens in sickle cell anemia? Sickle cell anemia is a condition common in West Africans, and in sickle cell anemia, the RBCs are already sickle shaped as a result of a mutation which causes the hemoglobin chain to stick together. So the parasite will also get damaged by this sickling. The people with the sickle cell allele are protected against plasmodium because their hemoglobin under low oxygen condition contract into the needle-shaped clumps. And this contraction not only causes the sickling of the cell but harms the parasite. Parasites are impaled on the clumps and the cell loses its ability to pump potassium, which the parasite needs. See, it as a sickle cell RBCs. These are the normals. When sickling is there, if the parasite goes inside the cell, it damages the parasite. So the parasite would not be able to infect this cell. As this is again happened in glucose 6-phosphate dehydrogenase deficiency, there are hundred of alleles known which and with more than 400 million people affected, glucose 6-phosphate deficiency is the commonest enzyme deficiency known. People with thalassemia make the ingredients of hemoglobin in the wrong amounts, and too many or too few alpha and beta hemoglobin chains are produced, and when they are assembled into the hemoglobin molecules, here the chains are left over. Extra chains clump together and causes a major problem in the cell. These clump grab the oxygen, don't encloses it, and the oxygen often escapes, and because it is strongly charged, the oxygen damages other molecules in the cell. This severe thalassemia is fatal, but mild form protects against malaria because the loose oxygen severely damages the parasite and renders it unable to invade the new cells. So it is again working as a protective factor. There are some other mutations like ovocytosis. In this, it happens in Asia. Some genetic Asia and some genetic rules and consequences as a sickle cell anemia. People with ovulocytosis have blood cell wall that are so rigid that can't slip through the capillaries, and the rigid cell wall make it hard for the parasite to enter the cell, and cell's rigidity appears to prevent the parasite clumping in phosphate and sulfates it need to survive. Sometime your examiner will ask, tell me the mutation and the diseases, pre-existing diseases which are working as a preventive factor for malaria or plasmodium will not affect that people, and why. So this is the answer. Then one major advantage of these various anti-malarial mutations appears to be that they provide a natural vaccination program for children. By slowing the development of the parasite, these mutations give a child naive immune system time to overcome Plasmodium's attempt to elude the immune system and mount an immune response. Mild cases of malaria thus immunize the children to malaria and allow them to survive to the adulthood. Now, what is it? Lab diagnosis. Three developmental stages are seen in the blood film. That definitely we will go for the peripheral blood film count. We can see the trophozoites, chyons, and gametocytes. And one more thing I want to let you know that now there is a test with malarial antigen and antibody is also available. Diagnostic points is small, regular, fine to flashy cytoplasm, infected RBCs, not enlarged. There can be multiple infection, double chromatin is there, marginal forms are there, ring, comma, marginal. Different forms are seen, which we have seen during the development of the malaria. So now, what is the prevention and what is the action of anti-malarial drugs in the different life stages of the malaria parasite? Uh, these are the drugs. You can see the gametocides, paraquine, sporonocytes. These are the many. Chloroquine is the drug. Actually, chloroquine is a drug of anti-malarial drug, which is very effective for that. The course has to be given. So this is all about the plasmodium. I hope you understand the lecture. If you have any query, please mention it in the comment box. I will try to resolve it. It is a hard topic. Please read the KD Chatterjee, which is a very good book. And thank you so much. Bye bye.